So now we are going to talk about intracranial pressure, which is really, really important to know the signs and symptoms of, and especially how to treat. There's a picture of a young boy. I thought it was kind of interesting. I just did, Google Images to find ICPs. You don't find patients very often with a full head of hair. A lot of times it's shaved off, and no head dressing. So you can kind of just see his intracranial pressure here. He had a brain tumor, and it was successfully removed, and he had a really good prognosis. So intracranial hypertension is basically if the pressure goes above 15. Now 20 can be used as well, but typically a normal ICP is about 10 to 15 or less. And if it goes higher than that, it really requires prompt determination of the cause, and it needs to be treated like, pronto. Really is treated as a medical emergency. Cerebral blood flow accounts for about 750 milliliters per minute, which is about 15% of your cardiac output. And remember what's one of our most important jobs, and that is to be a perfusionist. So we want to make sure that we're getting good cerebral blood flow to that brain. So if the ICP goes up, that's going to decrease blood flow to the brain and will potentially have really tragic effects. So cerebral perfusion pressure is something that we can calculate. So we'll figure out what the mean arterial pressure is, and we'll subtract the intracranial pressure, and that will equal the cerebral perfusion pressure. So that's MAP minus ICP equals the CPP. So mean arterial pressure, I'll show you how to calculate that in class, but essentially it's just systolic minus diastolic divided by 3, and then add the diastolic back in, subtract the ICP, and there you go. On the slide it says below 50. Many ICUs uses the number 60 as a guide. So if it's below 60, you're in big trouble and your brain is not getting the perfusion that it needs. So so let's talk about specifically what compartments and how we want to treat the ICP. So inside of your cranium, inside that box, there's basically 3 things, and that's your brain, and that's the biggest area, brain tissue, and that's 80%. And then you have blood vessels, so arteries, veins, etc. That's 10%. And then the remaining amount is cerebral spinal fluid, which is another 10. So brain tissue edema would account for the biggest part of increasing intracranial pressure. So there's something called the Monro-Kelly hypothesis, and that is a hypothesis that says basically in order to maintain normal intracranial pressure, a change in the volume of one of those compartments must be offset by a reciprocal change in the volume of another one. So if your brain tissue edema goes up, then we have to decrease the CSF, or we have to decrease the size of the vessel diameter. So something's got to give, basically, is the Monro-Kelly hypothesis. So normally in our compensation in a daily basis to an increased pressure, like for instance, when you sneeze, I think your ICP goes up to like 200 or something, some crazy amount, but it's just for a few seconds, so it goes right back down. But if you did have something where your blood volume, for instance, maybe you had some vasodilation, then normally our body would take care of that by decreasing the CSF. So it just balances itself out without any difficulty. Not so much when you have an injury to your brain. So let's go over some intracranial pressure signs and symptoms. Really important that you know early signs. And of course, number 1 is always going to be level of consciousness. So making sure that patient is oriented. You could see the patient just getting more restless, kind of fidgeting around, or even lethargic. So pupillary dysfunction would be the next thing you'd be looking at. Changes in vision, blurred, diplopia, etc. Any deterioration of motor function, sensation would go along with that, and a headache. So those are kind of more early signs. Later signs, of course, way more serious. Patient could actually go into a coma. Their pupils can be fixed and dilated. No reaction to light at all. They could be paralyzed on one side. Vomiting can be a pretty bad sign as well. So the big thing that you're really worried about is that the brain would get so much edema that it can't expand. And so the cranium, of course, is like a vault. There's no way for it to, when you're a child, you have fontanelles that will actually bulge, but not so much when you're an adult. So you're kind of screwed with your cranium, and the only way the blood can, or the brain can expand would be down through the spinal cord. So we're super worried about herniation through the spinal cord. So Cushing's triad is something that we really need to know about. So commit these signs and symptoms to memory. So hypertension, bradycardia, and then you can have some irregular respirations with that as well, but classically Cushing's triad is increased blood pressure, widened pulse pressures, and bradycardia. Okay, so we'll talk about that again in just a second. But other signs can be, as we think about what is inside that brain, there's things like the hypothalamus, the pituitary gland, and those also can cause problems. So we could say that they have thermal regulation problems with increased ICP. Most often it's a high temperature, so hyperthermia. Okay, so there's a slide here just on Cushing's triad. Again, sometimes you'll see irregular respirations on there, but most of the time, if you're just a Puritan, Cushing's triad really is three things: high blood pressure, widened pulse pressures. So what does that mean? It means that if you take a blood pressure, a systolic and a diastolic, and your blood pressure is 130/80, then the next time you take it, it's 140/70 or 150/60. Do you see the difference between the systolic and the diastolic widens? So that's called a widened or increased, same kind of thing, pulse pressure. So increased blood pressure, widened pulse pressure or increased, and bradycardia. Sometimes they add in respirations. Okay, now treatment of the ICP. So the goal, of course, is to make sure that we have good perfusion to the brain. So maintain that cerebral perfusion pressure. That's ultimately your goal. So how do we do that? Well, we can fix the problem. So surgery, they could put a drain in directly into the ventricle of the brain and drain some cerebral spinal fluid. Or sometimes a ventricular peritoneal shunt, a VP shunt, is placed. So there's, remember, three components of the so as we think about treatment for intracranial pressure, we need to kind of reflect back on what are the areas or the compartments of the brain that potentially are a problem. So we have brain tissue edema, we've got the vascularity, and we have the cerebral spinal fluid. So remember, the biggest component is the brain. That's 80%. So we want to try using some methods then to decrease brain tissue edema. So one of the most common things to do is use a diuretic called mannitol. Now that's an osmotic diuretic, and so it basically works by pulling the fluid from the brain and putting that into the vascularity, and then of course it gets excreted from there. So monitoring is really important. The serum So monitoring serum and urine osmolarity, serum and urine electrolytes are really important, as well as just fluid status for this patient. That's super important. Mannitol, you'll see that used in ERs and ICU. It crystallizes really easily. It needs to keep warmed, and you must use a filter in order to give this medication, so you don't end up giving the patient little crystals. So definitely use a filter. And things to kind of avoid would be giving mannitol to maybe a patient that has CHF, because it could cause fluid overload. And then giving hypertonic saline, HTS, is an alternative, and being used more and more in ICUs. So it's a great choice in decreasing cerebral edema. It can increase the, well, of course it will increase the sodium level, and that will cause an osmotic effect, and that essentially will shift the fluid from the brain tissue then. So it, interestingly enough, can inhibit inflammation and stimulate atrial natriuretic peptides. So if you remember about those, that will decrease fluid on the whole as well. 3% normal saline does its best work in the first hour of injury. So basically it is given as an infusion, and the rates are 0.5 to 1.5 milliliters per kilogram per hour. The ultimate goal is to decrease that ICU, there's a typo there, ICP to less than 20, and again, depending on the provider, it could be even less than 15. So benefits of using 3% saline would be that it helps preserve that intravascular status, so it can be given when a patient has a low blood pressure. Whereas if you're giving a diuretic, that could be a problem. So 3% saline generally increases that serum sodium approximately 1 milliequivalent for each milliliter per kilogram given. So careful to monitor serum osmolality again, and sodium levels when giving this hypertonic saline. Loop diuretics can be given as well. That can help with some cerebral edema. Those are second usually to trying mannitol. Corticosteroids, really controversial. In fact, steroids are controversial just across the board, especially in shock, but they are proven to show a decrease in cerebral edema associated with brain tumors. And the role in traumatic cerebral edema really is uncertain. So certainly steroids have a lot of side effects, and a lot of neurosurgeons have veered away from them. Those who have been practicing a while have a tendency probably to use those. I've seen dexamethasone used a lot in my own practice. I think it's helpful, but again, thinking is much different than what is clinical evidence. So if you see Decadron or dexamethasone on a MAR, now Decadron can be used for a million different things. Dexamethasone can be used for nausea even in cancer patients, but typically think about dexamethasone, Decadron being used for cerebral edema or spinal cord edema. Those are two of the big uses. A barbiturate coma, you may hear that. Pentobarbital is the most often used. It's really rarely used now. So putting someone in a barbiturate coma is I just haven't seen it for I don't know, over a decade. But basically what the pentobarbital did was it decreases the cerebral metabolism and the oxygen requirements to the brain. So that would basically decrease the ICP and allow the patient's brain cells to withstand a decreased cerebral perfusion pressure for a while. patients typically now are given benzodiazepines like lorazepam or midazolam, Versed, or even propofol, Diprivan, for sedation. So we really, really want to reserve the patient and make sure they're really sedated, so they're not using up more cerebral metabolism. Another thing, non-pharmacological methods. So basically what we did is we just kind of talked about how would we control brain tissue edema, the 80%. Now, the other two things to think about would be the vascularity, so the vessels within the brain, that's another 10%, and then the CSF. So how could we potentially cause cerebral vasoconstriction? Because if we did, then that would make a little bit more room, right? If you have some vasodilation, that's going to expand the blood vessels and increase the intracranial pressure. So according to the PCO2 levels, if it's kept on a low side, so typically we like to keep that as close to the low end as normal as possible, but a low of 30 has been used. Back in the old days, it went way down, even to 25, but that causes cerebral arterial vasoconstriction. So that will decrease the cerebral blood flow and decrease the ICP. So that's nice, and that's all good and well, but we don't want to decrease that PCO2 so low that we have a decrease in cerebral blood volume and decrease the cerebral perfusion. And that can cause cerebral ischemia. So be careful. So typically we like to just be on the low end of a normal PCO2, so around the 35 range. So that would deal with then the 10% in vascularity. Now to deal with the other 10%, which would be the cerebral spinal fluid. So one of the first things that we're going to want to do is just make sure that bed is elevated. So if you have a patient that's got an increased ICP, they should not be flat. They should be at least at about 30 degrees. That's going to promote good drainage of the cerebral spinal fluid and promote venous drainage as well. So, maintaining a quiet environment is going to be really important as well. So, just minimal contact with the family. Really important to educate the family and tell them. I mean, you'll see families in there just kind of screaming at the patient, trying to get them to squeeze their hand and just recognize their voice. And so just making sure that you create a very quiet environment is important. Fluid restrictions can help as well, about 65 to 75% of normal. Putting the patient on a cooling blanket can be helpful to create a little bit of hypothermia, again, decreasing metabolism, then cerebral metabolism. And then actually putting a drain into the ventricle, which is called a ventriculostomy, or a intraventricular drain. Most often I think it's called or referred to, is a way that we can drain directly that cerebral spinal fluid. So the next slide, you'll see measuring of the ICP, a couple little documents there on kind of how to do that. Now the place where the drain needs to be leveled is according to the foramen of Monro. So the ventricular drainage bag then is adjusted around the level of the foramen of Monro, and the neurosurgeon will tell if they want it right at that level or if they actually want it higher. So really important to remember the level in which you are going to place that bag. So again, foramen of Monro. And that's called a ventricular ostomy. So this is direct drainage of the CSF. The next slide, I I just thought it was so typical of an intensive care unit. So you see is a 4-year-old who was in a car accident, and here are the parents. And I think it just really captures the scene well. They're just glued to the monitor and watching probably an ICP or who knows what, just trying to be hopeful. So you can't really see the patient's face, but you see that there are 2 towels that are rolled up with tape on them on either side of the patient's head. This is to make sure that that patient has good alignment. Super important for a patient that has a traumatic brain injury. You want to make sure, and you see that this patient's sitting up at probably beyond 30 degrees, but really straight head. You don't want that head kinked at all. And again, just a real typical scene in the ICU. Poor parents.